Hello? Can you
Yes,
hear
sir.
me?
Yes, sir. Yes, sir.
Yeah. Good evening, everybody. Today, welcome to all for the ward rounds today. The purpose of ward rounds, I think, as I have told in the last class, is to test the knowledge and the ability of the student to see the patient, quick initial assessment, usually reserved for post-operative situations, but sometimes pre-operative as well. So, to see how the student has worked in the ward, how does he react to difficult post-operative situations, and what are the decisions he makes in terms of managing such patients. So that is the purpose of ward rounds. It is one of the facets that is assessed in the usually in the DNB exams. I'm not sure about the MS exams. Sanya, MS, there are ward rounds as well.
No, sir, we didn't have ward rounds. We
Okay.
had long case and short cases, and
Yeah,
followed by Viva.
Viva.
Yes, sir.
So the ward rounds is speciality of DNB and FRCS. I think it is essential. I don't know why MS hasn't introduced it. Okay, so let us go through a few cases. Start. Okay.
Good evening, everyone.
Yeah.
The first case is 32-year male. He presented with the complaints of pain abdomen on 24/9/2023. It was diagnosed to be acute calculus cholecystitis with a normal LFT and CBD not visualized in the ultrasound. Patient had a history of jaundice 3 weeks back. He was operated for laparoscopic cholecystectomy. He presented back again on 7/10/2023, almost 12 days after the surgery, with the complaints of sudden onset, 10 episodes of vomiting, which were non-bilious, and there was small quantity of liquid.
Nikita, on clarification, you said 3 weeks back jaundice. Was it prior to surgery or now after surgery?
3 weeks prior to surgery,
Prior
sir.
to surgery.
Okay. Was it evaluated
No, sir. He
prior to surgery at that time? When he had jaundice?
No tests were done, sir. He just said that he had jaundice.
Sir, actually, he went to the Ayurvedic doctor, sir, somewhere. So they've treated with some Ayurvedic medications. Later, they felt that it has been subsided. So
no. What we went to ask was it like a LFT documented jaundice or layman jaundice? He said he had jaundice.
Layman jaundice, sir.
Okay. Fine. Continue.
Yeah, continue, ma.
Now he presented with multiple episodes of vomiting, no history of pain, and on examination, his vitals were stable, abdomen was soft, non-tender. What is the further management? How to proceed in this case?
Okay. Vinod, let us go back to the first admission.
yes, sir.
Patient came with severe abdominal pain, vomiting, persistent vomiting. In fact, he had a bowl with him when he came with vomiting, and he also complained of pain that was radiating to the back. I was almost certain that he had acute cholecystitis or acute gallstone pancreatitis because he gave history. He is a very intelligent man. He's a software engineer, and he had all the information. So he said he has gallstones. So I thought he had gallstone pancreatitis. And so what investigations would you ask at that time?
Sir, LFT and amylase lipase are the main first three investigations, and ultrasound abdomen.
Okay, so LFT was normal completely, including alkaline phosphatase and gamma GT. The ultrasound showed acute cholecystitis. They said visual CBD is not dilated, visualized CBD is not dilated, and there was no intrahepatic biliary dilatation. So that was the findings. Amylase lipase was normal. He was tender in the right upper quadrant, and they said acute cholecystitis. Well, what would you do in this circumstance?
I'll go with the surgery, sir. Lap cholecystectomy.
Anybody in the audience would disagree with this? Niranjan, would you do anything differently?
Nothing, sir. I'll go ahead with surgery, but
Yeah.
I'll probably only the alarming this thing is you vomiting. If vomiting is there, invariably that's a sign of some kind of a CBD this thing involvement.
Ah,
But since we have proven that there is no jaundice, I would go ahead with surgery. But
yeah.
our this thing should be we should always be cautious when the patient has excessive vomiting in a case of gallstone.
He actually, I think he was mainly retching and he was complaining of back pain. So I was actually more worried about gallstone pancreatitis.
Correct, pancreatitis,
Yeah.
yeah.
So, but for our surprise, his amylase lipase was absolutely normal. So, which is why we went ahead with the surgery. I will just give you a brief outline of surgery. When we went in, I had never seen anything like that. The gallbladder was almost close to the falciform ligament. The duodenum was stuck to the gallbladder, and the gallbladder was stuck to the bile duct. So it was a very strange kind of situation. And even though we were able to isolate the callous triangle and we just demonstrated the cystic duct and its junction with the CBD, and I was still not convinced that we should clip it. So we mobilized the gallbladder a bit more, and we saw a duct-like structure coming into the gallbladder. Again, not sure what it was. So because we then had a very good window behind the gallbladder, between the liver and the gallbladder. So we went ahead and clipped the cystic duct. There was not much doubt that was a cystic duct. And then as we were dissecting, we found that the neck of the gallbladder was stuck to the CBD. And then behind that was the artery that was running into the gallbladder. So we clipped that and we sacrificed a bit of we did a kind of subtotal cholecystectomy, just a sliver of gallbladder stuck to the CBD because there was no plane between the gallbladder and the CBD. We just opened it and fulgurated the mucosa, and then we were able to do the cholecystectomy. The gallbladder contained pus in that, and it was very thickened and it was very inflamed. So we thought we had done the right thing, and then the CBD did not obviously appear very dilated at the time. He went home second day. He was absolutely fine. He came for a follow-up and he was fine. He was not jaundiced. I was worried whether he would be jaundiced or whether there was any problem. Abdomen was soft. He was eating and drinking. And 3 days later, he appears with this persistent attacks of vomiting. Now, Praveen, what do you think is happening?
Sir, there might be missed out stones in the CBD which is not detected by the
He is
ultrasound,
not
sir.
clinically jaundiced, man. How do you say it's missed stones? He's not
Sir, when
jaundiced.
there is
He doesn't have pain. His only complaint is vomiting. He doesn't have pain. He doesn't have jaundice. He doesn't have fever. So what do you think is going on? Nikita?
Sir, primarily I would suspect as it as a gastroenteritis, sir,
But
because it was sudden some food
yes, you
poisoning
can.
because of any abnormal food which he had last night.
Okay, one thing you suspect is gastroenteritis, but I would always urge you guys that whenever you operated on a patient, always think of some complication or some extension of the problem that was there before you think of other diagnosis. Always best to look at the operation that you have done and if there is anything that might be causing these symptoms. What could have caused the vomiting? I have explained to you the operation. There was quite a significant amount of inflammation. Would you think there could be subphrenic collection?
There
Which
could
could
be
cause
some leak or some collection.
bile leak and subphrenic collection. Yeah, that could be. But again, in that you may have fever and
Clinical
some pain also.
symptoms.
Pain or shoulder tip pain or something like that he may have, or back pain, but he didn't have pain. All he had was persistent vomiting. So atypical presentation. Vinod, what would you do? How would you investigate this man?
Sir, again I will go for an ultrasound abdomen, sir. As
Okay.
Was there icterus, sir?
Pardon me?
Was there icterus at this point of time?
No icterus.
No icterus. Okay.
No icterus, no fever, no pain, just vomiting. 10 episodes of vomiting. So, yeah, I would agree that you should get an ultrasound. Before that, any blood test?
LFT again, LFT and amylase and lipase.
LFT, amylase, lipase, total
TBC.
count also. Total count also.
TBC.
Yeah. Okay. Total count was normal. Amylase, lipase was normal. LFTs were normal, no jaundice. I think mildly elevated alkaline phosphatase.
1.3 or 1.2 just also.
And gamma GT and this one, alkaline phosphatase, were mildly elevated. I think it was 153 alkaline phosphatase and gamma GT was slightly, I don't know, I can't remember the
Borderline.
borderline in this one increase.
Yes.
And ultrasound, Nikita?
Yes, sir. It showed distal CBD stones, sir, which were multiple in number, and there was some collection in the operated site.
Okay.
The post-op collection, they considered it.
Yeah. Yeah. Okay. Now, how would you proceed? Sanya. Sanya, once you have this picture, how would you proceed further? Sanya, are you there? She's on call. Is she gone somewhere? Hello?
Hello, sir.
Is Sanya there or is she gone because she's on call today?
Oh. She's on call, sir, but
Sanya? Just find out. Okay.
yes, sir.
Vinod,
Yes, sir.
how would you proceed?
Sir, I'll do an MRCP and I'll plan for an ERCP to remove the stones, sir.
Why would you do an MRCP?
There are multiple stones, sir, but in ERCP we can see only the distal stones. If it is, it can give further details of if there is any very proximal stones and number of stones.
No, but ERCP will give you all the information you need. You just inject, you cannulate the CBD, you inject, and you will get all the information. See, in the exams,
yes,
you can actually tell. I will straight away go because see the situation is like this. If the post-operative situation where the patient has a lot of symptoms, LFTs are marginally abnormal, ultrasound is not very definitive. Yes, you have to get an MRCP before you consider intervention. Here, they have very clearly said that there are multiple CBD stones. So, I think, you can straight away say that I will consider doing an ERCP. Niranjan? Hello? Niranjan, what is your view? He may be on a call or something. Hello, Niranjan, are you there?
sir is there, sir, but
I think he may be on a call. Okay. See, as I said, that in a situation like this, post-operative, you can straight away say, I will go for an ERCP because the ultrasound has clearly shown distal CBD stones. Okay.
Okay, sir. When we will say for an MRCP, sir? Then
as I told you, when the picture is not clear, ultrasound, maybe gaseous distension, they are not able to see the distal CBD. The patient's symptoms are there, a lot of symptoms, pain, and maybe altered CBD, but altered left liver function test. But the ultrasound is not very clear as to what the cause of the problem is. Then you should have a roadmap. Then you can go for an ERCP. Other indication for an MRCP would be if the surgeon has said that the surgery was very difficult, he was not able to demonstrate the the scalous triangle and the structures very clearly, and he was doubtful, then you want to have a roadmap before you consider doing a intervention procedure. So
Okay,
then you get an MRCP done before ERCP.
What was the size of the collection, Nikita? Like how much of the collection?
No, I don't think it was. It
Around
was very
20
many.
cc, sir.
Okay, okay.
Just
Only
post-op.
the pitch.
uh,
Okay, okay.
So Niranjan, in this
Yes, sir.
situation, would you go straight for ERCP or would you get an MRCP done?
Straight for ERCP, sir. The information is very clear on
Yeah,
ultrasound.
that's what. That is why I questioned Vijay Kumar. He said the patient is so asymptomatic. I think he might have passed the stones. I want to be absolutely certain before I do a ERCP. That's why he got an MRCP done. Okay, you have the MRCP pictures, Nikita?
I do have them, sir, but I didn't put it.
Yeah, you can't put it now? Okay, fine. I think it would have been better if you had put that.
Sir, one
Okay.
doubt, sir.
Sure.
Sir, in the same case, in the first admission only, as CBD was not visualized, but clinically, as we are suspecting gallstone pancreatitis, which is not correlating with the ultrasound, can we do an MRCP in the first admission itself, sir, after the ultrasound?
No, your question is very valid, but not for the reasons you said. See, if, for example, patient has symptoms only for 2 days, okay, though he's been having pain on and off for the last 20 days, but this episode is for 2 days, severe abdominal pain. So in that case, your amylase lipase, if you suspect, we clinically suspected pancreatitis, and we got the amylase lipase done, they should have shown that if amylase lipase was elevated, then there was gallstone pancreatitis. But amylase lipase was absolutely normal, not even mildly elevated. So if it was mildly elevated, you could say it is on the way down and you think it may still be acute pancreatitis. So on the ultrasound also, they said pancreas was normal. There was no pancreatic edema or anything like that. So but this one, what your question is very valid. Why is your question valid? Can you go back and think and answer that question? Praveen, your question is valid because Niranjan asked that question. Is this jaundice that he had 20 days ago? Was it just patient felt the jaundice, or was the liver functions abnormal?
Yes, sir.
So, because there was that episode of jaundice, we should have, in hindsight, we should have got an MRCP done, because ultrasound, in again with the operation findings in mind, the duodenum and the gallbladder had almost completely obscured even the supraduodenal portion of the CBD, which is why the ultrasound was not able to pick up these stones. So maybe the MRCP would have picked up the stones, and then we would have done the ERCP. Okay.
Yes,
so the ERCP showed multiple stones, and they did a sphincterotomy, removed the stones and put a stent in, and patient is well, he has gone home. So,
sir, at this case, can we suspect a stricture, sir?
Can
we suspect a stricture, sir?
No, this stricture you can't suspect because there is no intrahepatic biliary dilatation. Stricture won't happen, suddenly. It is a fairly, so you will have, not only extrahepatic biliary dilatation, you will have intrahepatic biliary dilatation also. So you can't, at the moment, you can't suspect a stricture. So this patient, if you had the benefit of the hindsight, I would have done the MRCP and probably got a ERCP done, got the stones removed, put a stent in, and then went ahead with the cholecystectomy. But fortunately for our good fortune, patient was very well throughout this, even apart from the day of vomiting, he was very well, he tolerated the ERCP well, stones were removed, and he's fine. He has not had jaundice, he didn't have fever or anything. So even though we did the things the wrong way around, I think he's all right. But the circumstances are such. So sometimes the in the benefit of hindsight, I would have got a MRCP done in this patient.
Sir, is it like a partial obstruction, sir?
Which one?
This CBD stones, because it didn't develop anything.
He didn't develop pain, he didn't develop jaundice, he didn't have fever. Yeah, I think it is partial. It's like a ball.
Maybe how you can explain is there were multiple stones and one which was blocking might have gone away when the patient had developed vomiting, and that's why probably his jaundice was relieved or something. And then again the other stones came down and blocked it. We don't
So
know.
bowel valve
We
kind
can
of effect, a little bit of bile was flowing through, and so it was not that is why there was no massive dilatation of CBD or intrahepatic biliary dilatation, and he didn't have any fever, chills, rigors, vomiting, only vomiting. So I think he didn't have any frank signs of cholangitis. So I think we do get patients sometimes like this. We have to deal with it. Okay, next patient. So the lesson is, if there is any history of jaundice in the past, even though current liver function tests are normal, you have to have a high index of suspicion and think, why did he develop jaundice, and then get an MRCP done if the ultrasound is not very clear. Okay. What's happening?
Sir, can you see the screen, sir?
Yeah.
Okay. Second case is a 75 years diabetic female admitted with the complaints of vomiting and abdominal pain and distension since 3 days. She has a history of constipation. Passing of latest is not clear. Patient could not assess it properly. She has a history of open midline tubectomy done 40 years back. On examination, vitals are stable. On RT insertion, there was 1500 ml of bilious output. Per-abdominal examination showed gaseous distension of abdomen with bowel sounds being hyperperistaltic. How do we go ahead with the case?
Okay. Praveen, what would you do with this patient? This is the information you have.
By the signs and symptoms, he'll be suspecting the bowel obstruction, sir.
Okay.
So initially, to relieve the distension, we have to do a right tube incision, sir.
We have inserted that. We got a lot of bile out. Okay, that we have done. Fine. Then
next, for the management purpose, we'll be doing the CBC total count.
no, but first one more thing.
And
Patient is come to you with two things. One is vomiting and pain. What would you do? You have to relieve their pain. No, you have to.
yes, we'll start the analgesics, sir.
You have to. Patient making the patient comfortable is very important. Okay. Then how do you stop vomiting?
So, antiemetics by
you have to
giving
give antiemetics, and because the patient has vomited for the last 3 days, what would you expect?
Patient will be in dehydration, sir.
So you have to correct.
So you have to start the IV fluids.
Yeah, and check, and then you said investigations. What would investigations will you do?
Starting with the CBC to see whether any infections along with the HB levels.
Yeah.
Electrolytes to rule out hyponatremia, which may cause
hypernatremia.
to rule out
there will be possible hypokalemia because they're vomiting a lot. No.
Yes.
So
yes.
you would have lost a lot of potassium. So hypokalemia, and electrolyte imbalance, dehydration. Okay. Then what else?
And erect abdomen X-ray, sir.
No, before that, bloods.
Bloods.
You want to know whether the patient is diabetic, you have to get a random sugar. Then Nikita, anything else apart from what we mentioned?
Abdominal girth monitoring, sir, and for a
trial,
we can give an enema.
No, blood test. What else would you want to know? Somebody who's been vomiting for 3 days, dehydrated. Vinod?
ABG, sir, to
Huh?
see if she has any
Yeah, blood gases before that.
arterial blood gas.
Before blood gases. Whatever, when you send the blood, you will ask for this.
Serum creatinine and bun, sir.
Serum creatinine. You want to know whether there is any pre-renal failure because the patient is been vomiting. With dehydration, is a patient gone into pre-renal failure? So you want to know the serum creatinine. You want to know whether the patient is diabetic. So because you don't, history doesn't suggest that. And you also probably, because the patient has abdominal pain, distension, vomiting, you want to rule out pancreatitis because that is one of the diagnoses. So you have to get an amylase lipase done. And then, as you said, blood gases. Definitely. Blood gases will tell us whether the patient has got any metabolic acidosis. Okay. So you've done all these things. The patient has no renal failure. Creatinine is normal. And potassium is low. So you have started correction. And you said erect abdomen. So have you got the erect abdomen, Nikita?
No, sir.
Okay. Did we get erect abdomen done? When the patient came.
CT is done actually.
Huh?
CT was
Straight away CT was done, is it?
Ultrasound was done. Ultrasound showed no findings, so
Oh.
CT was done, sir.
Okay. But it is important to get an erect abdomen to see if there is definite obstruction. What else will you get? She's a diabetic. What else can you have? You can have perforation, no?
Yes,
So there may be free gas, pneumoperitoneum, gas under the diaphragm, and evidence of intestinal obstruction. Depending on the pattern, you may be able to ascertain whether it is small bowel obstruction or large bowel obstruction. Praveen, how will you say?
Any non-surgical cause you can think of which can produce this kind of a thing? Patient is diabetic.
Gastroparesis.
Diabetic ketoacidosis.
Diabetic.
If it is very severe, can produce abdominal pain as well as vomiting.
Correct.
But sir, bowel movements will be hyperperistalsis.
She has constipation. Bowel movements that is subjective. Sometimes you might have misread it. I'm just saying differential. You should think of it always.
Yeah, definitely.
Yes.
You should definitely.
Yes, sir. Yes.
What, Praveen?
Yes, sir.
Looking at the erect abdomen, how will you tell whether this is a small bowel obstruction or large bowel obstruction?
Did patient present to you emergency or how?
Patient was in the ward admitted, sir.
Already admitted in the ward.
Yes, sir.
No, sir.
He came as emergency.
Emergency, sir.
No, because why I'm asking you this question is if you guys have seen the first investigation you should have asked for rather than ultrasound was an X-ray, as sir was telling.
Yes, sir.
Who saw the case and why was ultrasound asked for? Why not X-ray? That's what my question was.
Abdul sir and things like that.
Abdul was on call, I think. Yeah. So, Praveen,
Sir,
how
yes,
would
sir.
you say that this is small bowel or large bowel obstruction?
Sir, in small bowel, there will be multiple air fluid levels, sir.
Even in large bowel, you can have multiple air fluid levels.
Dilation of bowel size, sir.
Yeah.
In small bowel, around there will be greater than 2.5 to 3 centimeter dilatation. But in large bowel, there will be greater than 6 centimeters if it is cecum. If it is colon, if it is cecum, it will be greater than 9 centimeter of dilatation, sir.
See, that is one thing, but you should say in the region, in the central region, if there is loops of bowel, dilated loops of bowel with valvulae conniventis, it indicates jejunal loops. If the bowel is dilated with no character, then they are ileal loops. If house striations are seen along the colonic, distribution, and if there is gas in the colon, then it indicates that the obstruction is in the colonic, because if you have a small bowel obstruction, you may still have gas in the large bowel, but it will be minimal. If there is significant gaseous distension of colon, then it obviously indicates that the obstruction is in the colon. Correct?
Yes, sir.
Because obviously the small bowel may also be dilated, but if there is significant amount of gaseous distension of large bowel, it may either indicate the patient is in ileus, or it may indicate the patient has large bowel obstruction. One of the two. But if you say the patient has a lot of pain and hyperperistaltic, bowel sounds, then obviously it indicates bowel obstruction. Correct?
Yes, sir.
Okay. What did the CT show, Nikita?
Praveen, will the patient have severe pain in case of bowel obstruction? Pain. What should you think of?
Sir, if it is severe pain, you should suspect of perforation and peritonitis, sir.
That is okay, but in
Yes,
case
sir.
if there is severe pain, what should be your suspicion?
Mesenteric ischemia, sir.
One, mesenteric ischemia. Second, bowel ischemia. It can be due to strangulation also.
Yeah,
If the internal herniation or strangulation going in for gangrene.
Sir, mesenteric hernia, is it acute, sir, or like episodes it will be there? Generally, after having food, they will have.
No.
It can be.
Yeah.
That is chronic mesenteric ischemia, no, sir, after postprandial listening.
Yeah, that is
Acute
intestinal.
will present with pain.
No, I think Niranjan is not talking about that. Niranjan is saying that when the patient is being in obstruction for a period of time, for 24 hours or more, the bowel goes into ischemia, because there is significant intraluminal pressure which impedes the venous return. So there is blood coming in, but blood is not going back. So the bowel becomes distended, and initially there will be venous gangrene, and if this continues, it will be arterial gangrene. So that is what he is talking about. So that is why they say in a virgin abdomen, never let sun set on intestinal obstruction. In post-operative situations, the dictum is different, because if adhesive obstruction has a tendency to correct itself on its own given time, that is, you have to decompress the bowel and allow it to untwist itself. So most of the time, 24, of course, you have to monitor them in a regular manner. You have to monitor their vital signs, abdominal girth, and see if there is any tenderness, as Niranjan said, and vital signs, if there is any new onset tachycardia, tachypnea. All of these things you should be watching. If the right tube is pouring out a lot of fluid, and then patient symptoms starts improving, then you know that the bowel obstruction in the post-operative abdomen will settle down. But in a virgin abdomen where no previous operation has been done, or at the onset itself the patient is in a lot of pain, and on examination patient is tender, you don't wait on such patients. So that is very important. So it is all about customizing your management based on the situation. Okay, Nikita, what is the CT report?
Yes, she did not finish 2 liters of contrast, sir. So with almost 1.2 liters of contrast, we could only visualize the contrast reaching up to jejunal loops, sir. And it was reported as dilated jejunal and ileal loops up to ileocecal junction with delayed passage of oral contrast, suggestive of small bowel obstruction, which was proximal to the ileocecal junction, sir.
Okay, right. Okay, so next, what did we do?
Yeah, I kept it open for discussion, sir.
Okay, so we know Kiran, I spoke to Kiran. He said, "Sir, I am definite that the contrast has not gone through. The contrast is not going through to the colon. There is definite obstruction. What will you do in this patient?"
Sir, I'll take up the patient for surgery, sir, as it is definite obstruction.
Okay, so what surgery will you do?
As sir, bowels are so dilated and we kept RT and decompressed, we can go for a diaglap and then we can proceed, sir.
Okay. Anyone wants to? Sania, would you disagree or agree?
Sir, I would agree, but if the distension is too much and no place to create pneumoperitoneum, I would go for an open laparotomy.
So
and
what
then
are the
proceed.
pros and cons of doing a diaglap versus open laparotomy?
So pros of doing diaglap would be, one is we'll come to know where exactly if it is an adhesion. Secondly, to an adhesion we'll come to know,
Yeah.
and we'll have a wider view, sir, to find out the site of pathology wherever is there, and depending on that we can plan our management.
Okay.
But you're creating pneumoperitoneum would be a fun because already distended bowel and the chances of perforating the bowel while entering is high, sir.
Correct.
And
And
so
what
in that
are
case,
the other disadvantages?
Disadvantages of laparoscopy, sir.
Yeah. See, there is very little space for you to maneuver the bubble around. Dilated bowel, inflamed, edematous. So handling such bowel will be a problem. It may cause serosal tears and sometimes even enterotomies.
Perforation. Yes, sir.
Enterotomy. So you have to be very careful. The only reason to doing a diaglap would be, as you said, to know the level of obstruction where it is, though they have on CT said it is near the terminal ileum. So you will know exactly what it is. Other thing for us to why anyone wants to do a diaglap in this situation is, if it is a band that is running across causing obstruction, it would be a shame to do a full-blown laparotomy just to divide that band. So in that case, if you divide the band, the obstruction is relieved and you have managed to cure the problem, which is the only reason you should be doing a diagnostic laparoscopy.
Yes, sir.
Niranjan? Hello?
Yes, sir, I agree.
Okay. So,
Hello? I agree, sir.
So fortunately, we did a diaglap, but abdomen at that time was relatively decompressed because lot of fluid had come out through the Ryle's tube. We did find that we would be able to safely enter. We did through the Palmer's point, and there was, true enough, there was a lot of adhesions at the site of the previous open, tubectomy site, and those bands were running from the abdominal wall up to the right iliac fossa across the dilated loops. And then we found that nearer the terminal ileum, there was something very firm to hard. Obviously, diagnostic laparoscopy, the haptic feedback from the bowel is not as good as you would do with open, when you handle the bowel itself. But we felt something very hard and, not, it was not moving either. So it was firmly stuck there and it was very, feeling firm to hard. And rest of the bowel was dilated. Large bowel was normal. Appendix was normal. There was a little bit of free fluid in the right paracolic gutter. So Vinod, now this is your diagnostic laparoscopy finding. There is bands have been, released. Still the obstruction doesn't seem to be relieved. So what would you do now?
Sir, I'll do a bowel work, sir.
We did a bowel walk laparoscopically. We could see that, as I said, there was some, for the first 15-20 centimeters of the terminal ileum was very firm and the lumen was very dilated, and on the surface it appeared abnormal. And then the rest of the bowel was edematous and dilated. We went up to another 4 or 5 feet. It was dilated and edematous, but nothing abnormal. There was no other pathology. Cecum itself was normal, appendix was normal. So terminal ileum, this thickened loop of bowel. Apart from that, the rest of the abdomen was normal. So what would you do now?
I'll open at that stricture point, sir.
Would you open laparoscopically or what?
No, sir. I'll convert
Where
into
will you make the incision?
sir, exactly at the location of the stricture point.
So that is what incision would you make?
Sir, as it is close to IC junction, mostly I'll go with right iliac fossa incisions.
So that is the Lanz incision as for appendectomy. Yeah. As for appendectomy, that is what we did. We did a Lanz incision and we delivered that bowel out. What are the possibilities? We know it was like, you know, it was molding like a putty. The first, you know, the terminal 15 centimeters of the terminal ileum was firm to hard, and it was molding like a putty. It didn't feel like a tumor. What are the possibilities?
Sir, can't it be a stricture, sir?
There is no stricture as such. It was dilated, thickened, but not narrow.
And maybe a hard stool constipation.
Very unlikely. Where will you get constipation, you know, hard stools in terminal ileum? And it's
Yes, sir,
usually
yes.
liquid stools, no?
Yes, sir.
So not hard stools.
There is a condition called as fecaloma. If there is chronic constipation and this thing, there can be hard impacted stools which can get stuck in the ileum also. But that is a rare scenario. Commonest you should think about first.
He didn't have constipation before this. So yeah, I agree. So what are the things that you think of? Sania?
So I would also think of this thing, like you said, molding. Is there some fecal matter on this?
But as I told you, it's not fecal. It's firm. It's firm. It is not hard. It is firm. Hard when I was palpating it laparoscopically through the instrument, but when we felt it by hand, it was firm and it was molding. We could mold it. So I think anybody, Nikita, what are the possibilities?
One of it could be a trichobezoar, sir.
Trichobezoar,
in case
correct?
of psychiatric condition.
Trichobezoar.
Or it could be any foreign body which any foreign body which she had taken
without her knowledge.
Yes.
Foreign body, yes.
Dentures, because she's 75-year-old, it can be dentures which might have slipped off sometimes.
Dentures, yes.
And
trichobezoar are usually most commonly seen in the stomach.
Yeah.
Yes, sir. And undigested food particles, it could be this.
No. See, you have to think of common things. Can you not think of ball of worms?
Yes, sir.
It could be, you know, hookworm. You've seen many hookworm balls. Nowadays, it's rarer, but it still can be present. Pinworms can form a ball in that area. It could be a soft tumor of the small intestine, lymphoma or a cyst or something like that, which is filling the lumen. So you have to think of all of these conditions. So I was thinking more in terms of a ball of worm. And when we opened, to our surprise, we found phytobezoar, where the food, you know, all these long-standing food particles had formed a proper ball, and it was firm, and it is not like a recently formed stools which had formed, you know, hard mass. It was like, you know, this is something that's been going on for some time. And when we went back in history, she said she's been getting this abdominal pain on and off for the last 3 months or so. Pain would come and then it would go away. So it was, you know, subacute obstruction like picture, but then it finally went into full-blown obstruction. So we did the enterotomy, we delivered that entire mass, and then we, washed the bowel proximally and distally. We were able to then clear the entire bowel, and then we closed the enterotomy, like a structuroplasty kind of picture, and then put the abdomen back and, close the abdomen. Post-operatively, she did very well. started oral sips same day, and clear fluids on the second day, and soft diet on the 5th day, and she was discharged on the 6th day after surgery. So the presentation was made because it's a rare condition, phytobezoar, where the this food particles and the organic material forming into a ball, which causes this obstruction. And because terminal ileum is one of the narrow areas of the bowel, it is one of the common sites. Any questions?
Sir, if you're suspecting it to be any kind of tumor, sir,
Yeah.
would you do an enterotomy if you're suspecting a tumor rather than so?
See, the CT did not show a tumor, so it was unlikely. But if it did, then we would have to do a right hemicolectomy, because it is so close to the cecum, and to obviously get good oncologic clearance, you would have had to do a right hemicolectomy. But opening the abdomen would convert that to a T4. I agree.
Yes.
Sir, and sir, after adhesiolysis, how many minutes generally will wait, sir, that we suspect that something other than the adhesiolysis?
See, the thing is, normally with adhesiolysis, you will have a point obstruction where there will be dilated bowel and there will be collapsed bowel beyond that.
Yes, sir.
Here it wasn't the case. So the adhesions were removed, and possibly adhesions might have played a part in it, but it was not the cause of the obstruction. You usually know, it will be a tight band running across the bowel. It is
Yes, sir.
not just usual standard adhesions. You will see usually these are congenital bands. Of course, you can get post-operative adhesions can also cause bands, but generally the obstructions that are caused in small bowel is usually or what is called as ileosigmoid knotting, where you run a band across and then sigmoid will come and roll around it. So these are all congenital bands generally, but you can also have a post-operative adhesion, one band running across and causing obstruction, but you will have a point obstruction where there will be dilated proximal bowel and collapsed distal bowel, and the bowel probably would have twisted also. Okay, next case.
A 53 years old male admitted with complaints of pain abdomen. Is a post-operative case of adenocarcinoma sigmoid colon, status post subtotal colectomy plus ileosigmoid anastomosis. He had post-operative history of esophageal candidiasis, lower respiratory tract infection, and urinary tract infection. On POD 29, he has complaints of abdominal discomfort and discharge from the drain site, which was removed on POD 7 and had no discharge till POD 29. Patient is tolerating soft diet but did not pass stools for the last 2 days. On examination, there was abdominal distension and the surgical site wound was healing with serous discharge. There was fecal discharge from the drain site.
Nikita, day 29 after surgery, will you still call the site wound is healing? It should
Yes,
have healed by this time.
There was surgical site infection, sir, and
so then you can't call the wound as healing. That is what I'm trying to tell you. You either mention SSI, you can't tell the wound is still healing on day 29.
Okay, sir.
If it is a normal healing, it should have healed by this time.
Yeah. Right. How much is the discharge from fecal from the drain side?
So it's like 30-40 ml, sir.
Okay. Right. Now, how will you manage that, Vinod? What are the problems that you are anticipating in this patient?
Sir, it's probably a leak formed into a fistula tract, sir. So,
Okay.
And as it is a low, like 30-40 ml, it comes under low fistula.
Okay.
So it's like a conservative management, sir, and we'll provide orally food. And if the patient is normally passing stools, like we can wait for as a conservative management.
See, you are jumping into conclusions. Don't you want to see? I agree, the amount is not much, yes, but you still have to establish a
Vinod,
lot of
where you have
things.
done the anastomosis? Where have you done the anastomosis? It is at the sigmoid colon or rectum. Rectum. Okay.
Sigmoid.
So how much amount of stool fecal matter you expect? So thinking like that, it will be still significant. 40 ml of fecal matter coming out from the drain side. If it is thick fecal matter, then it is significant. And patient is having pain abdomen also. So you can't jump the gun, and that is why we were telling you yesterday also. Don't jump the gun and say that we will manage conservatively and all that. Just say what are your options.
Yes, sir.
Now, where is the drain site?
In the left lumbar area.
Left lumbar. Okay, so and the anastomosis also in the left
Same
iliac fossa. Left iliac fossa, correct?
Yes, sir.
Okay. So now, first of all, you have to establish the site of the leak.
Yes.
Other thing, what other things? Remember what Dr. Lakshman said. What other thing you need to rule out in this patient?
Abscess, sir.
Correct. So if this is a anastomotic leak, which is communicating with an abscess cavity and then coming out, your management will differ.
Yes.
How will it differ?
You have to drain the abscess.
Correct. You have to drain the abscess. So first of all, establish, you have to, either because it is the anastomosis is, closer to your rectum, you may want to do a gastrographin study to show where is the site of the leak, or you can do a CT abdomen with contrast, both oral and rectal contrast, to demonstrate the leak.
Yes, sir.
You have to demonstrate the leak and see the size of the leak. Is it a end fistula or a side fistula? And then
Yes.
other thing is to demonstrate whether it is communicating with an abscess cavity and then coming out, or is it coming out straight, as a tract outside. So those are two important things you need to know. And obviously, because the patient has already been scoped preoperatively, and the sigmoid and all those areas are normal, you don't expect any disease in the. So other thing you have to rule out is distal obstruction due to disease, which in this case is probably not there. So these are the things you have to establish: the site of the leak, communication with the with a possible abscess cavity, and then whether it is an end leak or a side leak. So then you can make a decision about how to manage it, not before that.
Yes, sir. So,
Okay. What are the options you have now? Let us say you have at the anastomotic site a side leak. Okay.
yes, sir.
So you have all the endoscopic facility in your S1. So what will you do?
We'll, first of all, if the collection is so much, we have to drain it out, sir.
Yeah, there is no collection.
We can go for a stenting, sir.
Stenting, covered stent, you mean?
Yes, sir. Covered stents.
You can do a covered stent, but covered stent will be very expensive. It is definitely an option, but more simpler than that. Possibly it may work. If it is a small leak,
These gels.
glue,
Glue, sir.
cyanoacrylate
More
glue.
than glue, you can clip them.
Clip them or glue them. Yeah, clip I think is probably better. So if it is a small leak which you can demonstrate, you can clip it, but you have to keep the patient nil by mouth for a few days for the hole to seal. So
Yes.
you may have to still give them enteral TPN, because you don't want any fecal matter coming through. You want to keep that area dry for a period of time. So you give them TPN for a period of 5 days and then do the glue, or before, do the glue and keep them nil by mouth for a period of time and give them TPN. Or other thing is, if the patient is well and the output is not very severe, you can go on to low residue diet and see what how the fistula behaves, whether it closes, whether the output from the fistula comes down. And so for all these things, the patient should be well. And as Niranjan said, if the patient has pain, the patient has fever, you can't consider conservative treatment. You'll have to think about some intervention. If the patient is asymptomatic and afebrile and is able to tolerate feeds, then you go get the dietitian to give him a low residue diet and hope that the fistula will close. Low
Yes.
residue, high protein diet and allow the fistula to close.
Sir, that's what my question, sir. If it is a stool and if it is a low output fistula, will you wait?
See, as long as there is no generalized abdomen peritonitis, there is no leak, into the general peritoneal cavity, there is no abscess cavity communicating with this fistula, you can wait. It will possibly heal. So definitely conservative treatment is one of the options. But that is what Niranjan was telling you. You cannot jump to the conclusion that you will conservatively manage till you have established a lot of these factors.
Yes,
That this is a side fistula, that the bowel is healthy, there is no communication with an abscess cavity, and the quantity of the fistula is low. Only then you can say, I will manage this patient conservatively, provided there is no deterioration or any new onset symptoms are there.
Yes.
Niranjan, what do you want to add anything?
Nothing, sir. Same thing. What was the findings here?
Did you
CTs. CTs.
Yes,
Huh?
Just plain CT was done, sir. There is a serous collection of in the psoas muscle area. So now the patient is also complaining lower limb pain. So they advise for contrast. Just started contrast, sir. Not yet completed.
Okay.
No, why not done earlier? Rectal contrast you could have given. No, simple thing. Not even oral contrast.
Rectal contrast given, sir. But because of stools, it is not passing till the level of anastomotic site, sir.
Stools,
Yes, sir.
Where your anastomosis is so high up.
It's ileorectal, ileosigmoid.
You can give, you could have probably given an enema or suppositories and made the motions to come down, and then you could have given.
Enema and Dalcolex has given, sir. He passed stools also, but still it is there.
Okay. Right. Okay, let us wait for that. So contrast, and then if there is a collection, you will have to drain that first.
Yes.
But when will you intervene? When will you go for a surgical intervention in this case? How much is total count?
9,000, sir.
Okay.
9,000. Okay. And how is the general condition of the patient? Is there any gross distension? He's taking oral diet.
He's taking oral diet, sir. Gross distension actually when the admission was there, but after that, after giving enema, he passed a bit of stools. Then it has been settling, sir. But there is a fever spike, sir.
So that means there is some sepsis going on.
So if you drain the collection, the fever size spike may come down.
Yes, sir.
Okay. See, the thing is, I think what Niranjan was saying is any evidence of peritonitis, evidence of general sepsis, which is not resolving. And if the fistula output, how long will you wait? Let us say 30, 40 ml keeps on going till about, let us say 2 months. Will you wait?
Sorry, sir, no idea.
No idea. Sania? Sania, are you there? She's gone back to emergency, is it?
Yeah, I think so.
She went to see the patient, sir. Ma'am went to see the patient.
Okay. Nikita, what do you think?
We can't wait too long, sir, because epithelialization occurs and the tract doesn't settle on its own after 1.5 months, sir.
See, it is a toss-up between. See, the thing is, you should the post-operative period. There will be additions. There will be sort of lot of inflammatory adhesion, which will be, and entering the abdomen itself will be difficult. So you have to wait a reasonable period of time, provided the patient is well. Patient is not well, what would you do? As Niranjan said, if the patient is not well, you will have to go in. What will you do?
Just a drainage of whatever the collections and diversion elastomy.
So what you will have to do is you have to first inspect the anastomosis. If
Yes,
the anastomosis looks healthy and only one area there is a leak, then you are justified in suturing that but giving a proximal stoma
yes,
to
sir.
protect that till such time that all this heals, and then you can close the stoma. If the anastomosis does not look very healthy, then you are well within your rights to
And
do a double barrel, bring out both the proximal and distal ends, so that you can at a later date do a reanastomosis. So you bring it out as an ileostomy, and also the sigmoid colon as a mucus fistula. So you may not have to do a proper laparotomy then. You will be able to just circumstomal incision, mobilize both the proximal and distal bowel, and anastomose it. So double barrel, bringing out both the ends as a stoma. So that is one option. If the bowel looks quite healthy and the anastomosis looks quite solid, then just suturing the hole in the anastomosis wherever there was a defect, close that. But you can't think that what has not healed before will heal now. Patient has now 2 or 3 months down the line, nutritionally maybe not so good, sepsis, subclinical sepsis will be there, so healing may not be very good. So you have to give a proximal diverting stoma, and obviously wash out the abscess cavity, put a drain and come out. Okay.
yes,
Any questions? I think 3 cases. We will discuss that next. I think there is a lot of learning from that bariatric surgery case, which we will
yes, sir.
discuss next time.
Yes.
10 o'clock now, so we will stop.
Okay.
Okay. Any
Yes, sir.
questions? All the 3 cases we discussed.
No,
There
sir.
are no questions. Okay. Good night, everybody.
Good night.
Good night.
night.
Sir.
Thank you.
Thanks.
Thank you, sir.